So, good morning. I'm going to talk a little bit about the timing of pulmonary valve replacement after repair of tetralogy of flow. When I got this topic, I'm like, yes, right? Guidelines, easy, everybody has been taught how to do this, right? But when you stop and you look at it, and you look at the guidelines and you say, what is that based on, and what do we truly know to support these guidelines? This talk actually took a little bit of time to put together. So what do we know? Well, what we know for sure is that tetralogy flow is four things. Session on tetralogy flow, thought we should have this slide up once, okay? Most people in this room will know this. But what happens in surgery, though, is that it's changed over the time, right? We used to have blade-lactosic shunts, pot shunts, water shunts, central shunts, modified blade-lactosic shunts, and then late repair. Now we repair early. But all the different stages of repair and all throughout the time, the end result is the same. We close the VSD, we open the RV outflow tract, we have to do something sometimes to the pulmonary valve, we try to preserve the pulmonary valve, but we all know there's anatomic variance. In all those techniques that we do, it all depends on the anatomic, but the end result is the same. We have outflow tract obstruction potentially, and we have probably a lot of pulmonary regurg and other complications. Early survival today is outstanding, 98%. When we look at long-term outcomes, it also is excellent. And in fact, when you look at those that are corrected in 1965, the 40-year follow-up in papers, if you look at it, it's still really good, in the 70 range somewhere. And then if you look at the top group, the 1985, you can see the survival is improved. And again, those techniques, the timing of surgery and all we do. And again, there's a 40-year survival rate of 90%. This is outstanding, and really another credit to what congenital heart disease, the field has done in trying to always improve what we've worked on generation by generation. What we all know, though, is late complications are common in this group, and survival doesn't tell the whole story. And that's true for every single one of our lesions. Survival is not the only story anymore, and late complications is really something that the adult congenital world really focuses on. We know that these patients have exercise intolerance, there's a risk for heart failure, a risk for arrhythmias, and really there's a risk for sudden cardiac death. And we'll have a speaker that will talk about those features, those factors of this. But we also forget, though, is that they have extra cardiac complications. In the last 6 years, there's a lot of literature now talking about, even in the, quote, good tetralogy flow patients, no matter what age they are, there's an incidence of renal dysfunction greater than the general population, restrictive lung disease, the impact that that has, liver disease in the tetralogy flow. We talk a lot about it in Fontans, but I challenge you, look at the liver in those that had late repair of tetralogy flow. I think you'll be surprised what you find. Again, learning disability. What is the actual impact of all those surgeries and cyanosis for 5 years? A lot of focus in the pediatric group trying to improve the next generation, but I challenge you in the room to go and look at your adult congenital population. How many of those actually had learning disabilities, ADHD, and actually needed help in school? In fact, there's a session later to talk about it, not to steal Dr. Franklin and his team's thunder, but when you look at it, we just started screening our patients in our clinics, and the first 200 patients that we screened using neuropsych testing, 33% of them had a major issue in one area of neuropsych testing, 33%. That's the first 200. So again, big issues. In the end, what do these late complications mean? They have a huge impact on their quality of life. And so I'm back to survival is important. It clearly is a big deal. But again, it's not the only story, and these late complications are common. What we do is you look at the literature and you look at tetralogy flow. Death is bad. Really, death is bad. Ventricular tachycardia is bad, and arrhythmias. And so even though survival is good, there's this group of patients in tetralogy flow that die suddenly and have major issues. And so in the literature, there's a lot written on identifying those risk factors that lead to these late events: death, heart failure, and VTAC. And again, we're going to talk about VTAC. But this is a really important aspect when you start talking about this pulmonary valve issue and why the guidelines are. There's three themes in the literature when you look at these papers trying to identify these risk factors. When you look at the risk factors, there's history. A lot of papers talk, if you have unexplained syncope, Again, that's been in other things. Older age at surgery. So if you were one of those that had surgery to repair your tetralogy flow when you were 5 and you had cyanosis or a shunt for a long time, you were exposed to different hemodynamics than those potentially on the neonatal TET that we're doing now. Previous BT shunt comes out, and again, is that a marker of older age of a surgery or a surgical era? Probably, but again, it's on there. When you look at other big themes that you'll see in the literature is electrophysiology markers, and again, I'm sure we're going to hear a lot about this, but Q restoration 180, non-stained VTAC, Holter monitors, PVCs, all these things. And the third one, though, is hemodynamics. And so these are the 3 general themes when you look at papers in the literature about tetralogy flow, risk of death, risk of VTAC, and heart failure. Well, how do you tie all this together with this pulmonary valve replacement and timing talk that I'm giving right now? Well, when you look at that hemodynamic category, we know that there's a lot of late hemodynamic problems. My favorite question to all my fellows is, name the top 10 late complications following previous repair of tetralogy flow. If you can do 10, you pass my rotation, okay? So there's more than that, but it really challenges you to think, and you have to understand what happened to most of them. Clearly, volume lesions, residual ASDs, VSDs, those patients that had actually shunts and were cyanotic, they're set up for pulmonary hypertension. They're an animal model, a person for pulmonary hypertension. Increased vascular pressure, cyanosis, everything you see that causes pulmonary hypertension, those early tetralogy flow patients had it. Dilated ascending aortas, aortic regurg, again, that can be from damage of the aortic valve at the time of surgery when the patch was sewn in, or the big dilated aorta that we often see in these patients. Aneurysms, we put large patches and you get scar in there. Pulmonary artery stenosis, again, multiple layers, previous shunts, Waterston pots, BT shunts, all those things narrowing the pulmonary arteries. And then the pulmonary arteries themselves aren't formed normally. And then, of course, tricuspid regurg. Is that from RV dilation, or is it a combination of the septal leaf of the tricuspid valve being distorted at the time of the VSD patch closure? Also, you have that abnormal shift when you have a large Q restoration, right bundle branch block, and that septum and the way it moves causes tricuspid regurg as well over time. Well, the biggest issue, though, as we all know, is that these patients have pulmonary regurg. And how is pulmonary regurg a big focus, and where should we do with this, and how does this fit in? It's the most common indication for reoperation. I think everybody in this room probably knows that. You can read the different estimates. In general, it's about 50% risk at 30-year follow-up. Again, it depends on the series you read, depends on the group, loss to follow-up, referral bias, how many patients, large center versus community center. But in general, this is published data. Determinants of PR, though, are very interesting because if you stop and think about it, when you have a baby and you just do the repair, often if you have a transanular patch, you have a huge regurgent orifice, that's going to determine how much PR. But the RV is really stiff, so it's not compliant. It's not very compliant. And so that has a big aspect in how much pulmonary regurg. And then what's the pressure difference between the main pulmonary artery and the RV? If you're cyanotic early on, your RV pressure or your pulmonary pressure may not be normal, and so you have a difference. And then early on after surgery, your little baby that just had surgery, the pulmonary arteries are small and they're compassionate. How much volume they can take is limited. Then, of course, duration of diastole. Now take your adult patient who now has had surgery and has had pulmonary regurg for a long time. Well, the pressure differences are the same between the pulmonary artery and the RV. The compliance of the RV early on is really actually pretty good. And then that time, your heart rate comes down, and now you have more duration for pulmonary regurg during diastole. And so you can see how over time from being a child, a neonate, to getting a little older, that this changes. And those compactants in the pulmonary arteries, they accommodate more flow. And this, over time, leads to a lot more pulmonary regurg. And in fact, it causes issues with a lot of different pieces, including the RV. Well, again, how's the RV tolerate this? Well, it's tolerated for years. And in the 70s, 80s, and again, I don't think many people in this room would ever have said this, but there was a lot of people that actually thought pulmonary regurg was pretty well tolerated and probably benign. Clearly, that is not what we think now. But the compensatory hypertrophy, the compensatory mechanism of the RV really is what allows this to happen. And I think this is an important aspect when we're talking about the timing. What happens is you get cell elongation, you get addition of myofibers with the actual cells of the RV, and the collagen content actually goes down. This results in an RV end diastolic volume going up, but it's important early on in this compensatory phase, the RV end systolic volume doesn't change, really important. And then this maintains a normal mass to volume ratio. What that means is your RVH, your mass goes up, your volume goes up, but early on the ratio is normal. Really important part of compensatory mechanism, and the RV pressure is normal. This is similar to aortic regurg, but the RV is different. The fibers are arranged differently as a single coronary, but the pressure differences are different. But the RV is very similar to the LV in the setting of AI, and these are the compensatory mechanisms. What happens over time, though, is that the RV continues to dilate, but once those compensatory mechanisms are outstripped, now you continue to get diastolic volume increase, but now you get end-systolic volume increase. So end-systolic volume, when you see that start changing, it's a mechanism here that the compensatory mechanisms are starting to fail. Really important concept. And then the mass-volume ratio changes, right? Your mass doesn't keep up with your volume, so now the volume is much bigger, and your RV mass, your compensatory hypertrophy, doesn't actually work anymore. RV pressure increases, decreased contractility. You now get fibrosis of the ventricle and irreversible contractility, damage to the myocardium itself. This is when it fails. And I think this is really important for when we look at the guidelines. The end result is bad. Everybody has patients with tetralogic flow, understand that. But we really see this, is that the RV is dilated, you get RV dysfunction, filling pressures, atrial ventricular arrhythmias, tricuspid regurgitation, and heart failure. People don't think the liver's congested, we got varicosities, and we get lower extremity edema, and all this ends up in exercise tolerance, and a really bad thing is death. So we just took pulmonary regurg and connected it to a lot of things. Well, why does this matter? Well, the end result is when you look at the MRI studies, it's really told us a lot. This is data showing you that the RV dimension, the end diastolic volume, correlates early with pulmonary regurg. This is compensation, so compensatory phase here, and you can see as the pulmonary regurg increases, the volume increases. We also know, though, is that the RV ejection fraction also correlates with the RV end systolic volume. So remember, early on, RV end diastolic volume goes up, end systolic volume goes up, and now our ejection fraction starts to fall. And this shows us, that may help us with our timing of our pulmonary valve replacement. And in addition, you have an effect on your failing RV and LV. The MRI showed us a really unbelievable thing that we'd already seen. We showed that is that there was a failing RV. If your RV fails, your LV is also affected. And this is a beautiful study by Dr. Giva in 2004 who showed this correlation. As the RV ejection fraction went down, the LV was affected too. A really another important aspect that we didn't know until we really looked at MRIs. Why is this? Well, reverse Bernheim effect. Any fellow in the room know about this? I didn't know about it either until I read again, but this was a big important thing is that, and basically, and we all know this, it's the ventricular-ventricular interaction. If you alter your RV, it affects the LV, and in the end, this ventricular-ventricular interaction is not hard to figure out. The ventricles share myofibers. The superficial layer of the RV is continuous to the super layer of the LV, and then there's a deep layer of the RV that actually connects to the LV through the septum. So this is actually connected, and this was not surprising when we saw this by MRI. And in fact, you can take the heart and unravel it actually with these fibers being connected. You can actually unravel the heart, just shown here. So when you actually look at the contractility and you look at it by this, you suddenly see that the RV wraps around the LV, and you can see how if the LV is abnormal, it affects the RV, and if the RV is abnormal, it affects the LV. So again, when we look at timing, this was crucial. So back to our risk factors. Well, we just showed pulmonary regurg causes a lot of bad things based on the data. When you started looking at risk factors for heart failure, death, and sudden cardiac death, and death in general, we started seeing it. In the first paper in 2000, sure enough, showed pulmonary regurg, landmark study by Dr. Adkad-Sulis. Other things there, older age repair, CT ratio of 0.6, a big heart, PVCs, and then of course the classic QR restoration greater than 180. But when we start looking in 2008, Paul Carey, great study, and I'm sure we're going to hear more about this, but again, it showed us things that were high risk for sudden death were LVEDP, a marker of bad LV. And again, look at this. Down here was tricuspid regurg, and again, ventricular tach, which is another arrhythmia because of a bad RV. And then similar in 2008, we had another study that looked at those risk factors. And look what's happening. We went from 2000, pulmonary regurg is bad, markers. And in 2008, another MRI study showed RVEF, LVEF, and then again QRS restoration. Again, bringing all this back together that the mechanism of pulmonary regurg leading to these downstream problems cause issues. And of course, this most recent paper, 873 patients by my friend and colleague Anne-Marie Valenti, she actually showed it wasn't the volume so much, but she started talking about that mass volume ratio we talked about. And if you combine it with ejection fraction, and you also had atrial arrhythmias, you can see the survival, the risk of the sustained VTAC, and that was important, and it really went down. So we've taken pulmonary regurg, badness, problems with RV function, all related to all these things. And so from that data really comes the treatment strategy of pulmonary valve replacement. But there's a lot of factors to continue to consider when you're doing this. So this isn't easy. Risk of valve failure. Any valve you put in now will fail. Bioprosthetic valve, homographs, there's a lot of different things you can choose from, but in general, it's about 59% at 15 years. But again, this is a bioprosthetic valve. You guys can read about this, but in general, this is kind of where people talk. Mechanical valves, they've been done in this setting. There's a high incidence of thromboembolic events. There's a recent paper from the Middle East that showed that this may be okay if you treat with Coumadin aggressively. But again, in general, the bioprosthetic valves. But you also have to consider the risk of surgery when you're talking about these patients. Early mortality, 1% to 2%, so it can be done safely, but it depends on the age of your patient and other risk factors, and also what other procedures you need to do. The benefits of pulmonary valve replacement, though, is pulmonary valve replacement beneficial? This is a big deal, correct? Because we want to do it if we think it's benefit. So what's the data show? There is tons of articles in this, but this is the summary. Strong evidence, if you put a pulmonary valve in, pulmonary regurg goes away. Yes, right? We're replacing the valve, the pulmonary regurg should get better, right? Surgeons, yes. So we also have good data that the functional capacity that patients report also get better. And we have data that the RV diastolic volumes clearly get better, 30 to 40%. The degree of tricuspid regurg improves, again, debated in the literature, but 4 papers at least saying it does get better, at least some. And then global RV and LV function often gets better, but on average, if you look at the whole cohort, it's kind of unpredictable, and most of the time it stays the same, with those people at the far ends probably getting the most improvement, being worse or best with that. Mixed results is the last thing, though, is that there are some studies that say exercise parameters improve, there's some studies that Q restoration improves, and there's also some that says the arrhythmias actually go down. Problem is, there's other studies that say that none of that is true. So again, this is what we know in the literature, and you can read a little bit about that. The end is the last 2 slides is size matters, okay? Size matters. And what you look at, everybody's really focused on the MRI data of does the RV get better? RV recovery means gets to normal size and normal function. 2001, the cutoff reported was 170 mLs per meter squared, and this is RV end diastolic volume index. 2005, RV end diastolic volume index came down, 150 mLs per meter squared. 2007, well, we're back in between 170 and 150. We're now at 160 end diastolic volume index, mLs per meter squared. But look, RV end systolic volume index was reported as a marker. Remember what happens late? RV end systolic volume goes up in a failing compensatory mechanism. So I think that's important. And then Dr. Giva, again, had a similar result as the paper in 2007. And most recently, 2016, the group led by Dr. Bokum really looked at RV end systolic volume. And not only did the RV recover if it was under this end systolic volume, for one of the only papers, it actually looked at function. Function also improved, and there was a reduced risk for sudden death and sustained VTAC in that paper. And that's the first in my knowledge that actually showed this. So that was an important aspect that added to the literature. Limited data, though, in survival benefit, and there's really, what is the effect of age? I am 45 years old. I am not 20 anymore, okay? It's just not happening. But I'm not 50 and I'm not 60. So if you replace my pulmonary valve, does my RV do differently than a 60-year-old or a 20-year-old? The answer is the data doesn't tell us that and doesn't add age into this aspect when we're looking at it. So in the end, what are the indications for pulmonary valve replacement? Symptoms in the setting of RV volume load. Asymptomatic, if you have this is probably where we use, this is what we do at our center. We use RV end diastolic volume index of greater than 150. We look at that though, but what happens in my state is I got some big people. So indexes don't always work. So I use RV to LV ratio a lot of the end diastolic volume. Greater than 2 really helps me. RV end stock volume index is really important. If I see this going up, this is a marker that I think we have to pay attention. We use 80 as a cutoff. Ejection fraction important. Poorly controlled arrhythmias, progressive tricuspid regurg, significant residual shunt, obviously, and severe aortic valve regurg. Those aren't only indications, but you have these other ones, you should consider it. In the end, though, we're not going to talk about this. You got a lot of talk about pregnancy, but also you can't forget special circumstances. If a person wants to get pregnant, this is something to consider. In particular, if they have severe PR, a big RV, and dysfunction, the Paul Carey group really has shown that pulmonary regurg in this setting can be a risk factor. Those are my guidelines. These are what the guidelines currently are. Again, there's 3 different ones, the Canadian, European, and American. Again, it goes along with what I just told you. The American doesn't have the volumes involved. The Canadian does have some volume listed, and the Europeans, you can see kind of the similar stuff here. But again, I think that this is really where we're at and what the state is, and I hope I tied it together. Take-home points, survival is good, problems happen, pulmonary valve replacement can be done with low mortality, and there's a lot of good things pulmonary valve replacement do. Future direction, though, is what is the difference when you do age, how's age affect, and then the impact of percutaneous valves that we're going to talk about. I have no idea of everything I just said today, how that is really going to change or should it change in your setting. I will tell you is that I want to replace a valve before there's permanent damage to the right ventricle, and if I had a valve that was safe that could be done, maybe we would think differently. And with that, I want to thank you all for your attention and having me listen this morning. Thanks.